Thank you all for being here in the second in our series of 21st century webinars, with a particular focus this year on the intersection of racism, structural racism, and public health and the well-being of people and populations. I'm very, very, very honored and very happy to present today Dr. Oxiris Barbot, who will be speaking today about operationalizing health equity during a crisis. As you know, Dr. Barbeau was really actively involved, like hands-on during the COVID-19 pandemic, and we have a lot to learn from her experiences, as well as her experiences across her lifespan with regard to public health crises. Dr. Barbeau is like one of my favorite people in the world. So now I'm going to do the formal part of the biography after I've done the informal part of the biography, which is to say this. Dr. Oxiris Barbot is a physician, public health expert, and innovative leader at the intersection of public health, social justice, and healthcare delivery. Her commitment to social justice is the common thread throughout her career in advocating for health equity, children's well-being, and community health. Her career has been shaped and inspired by the dignity and courage of many patients she's cared for and communities she has served. She's currently an adjunct assistant professor at Columbia University Mailman School of Public Health and senior fellow for public health and social justice at the JPB Foundation. As the former health commissioner for New York City, Dr. Barbeau was instrumental in directing the city's response to the first wave of the coronavirus pandemic by taking science-informed actions that flattened the transmission curve and addressed racial inequities. I think today I heard the current mayor of New York say something like 87% of New Yorkers had at least one dose of a vaccination at this point in time. I don't know if that's true or not, but that's what he said. Dr. Barbeau made a priority of communicating with New Yorkers with candor and empathy. Completely. I loved watching Dr. Barbeau with those commercials, by the way, providing trustworthy information and a steady hand to lead the city through and out of its darkest days. While commissioner, she was named to Crain's New York Business Notable Women in Healthcare and City and State New York Health Power 100 and Nonprofit Power 100. Dr. Barbeau was Commissioner of Health for Baltimore City from 2010 to 2014, where she introduced a health in all policies approach to achieve better health outcomes faster. He was Medical Director for the New York City Public Schools, the largest school system in the country from 2003 to 2010. While there, she led the development and implementation of the automated student health record system, which helped improve individual health services for students and augment population health intervention for 1.1 million students. As a person whose husband is a New York City school teacher, very grateful for that. Although I would tell you things are kind of a mess right now, as you know, Dr. Barbeau. She started her medical career providing general and pediatric care to poor and uninsured families in Washington, D.C. Dr. Barbeau received her undergraduate degree from Yale University, her medical degree from New Jersey Medical School here at Rutgers, and completed her pediatric training at George Washington University Children's National Medical Center. It is my great, great honor. I am thrilled that Dr. Barbeau has agreed to be with us. Welcome to Dr. Oxiris Barbot.
Thank you. Thank you very much for that kind invitation. And I have to tell you that it's really exciting to be here with all of you today. I want to thank you for this opportunity to share some of the learning that I did during the crisis of COVID. And Perry, I want to thank you for your graciousness in making this possible and your leadership through this crazy time. So I think what I'll do is I'll just sort of jump into the presentation. I look forward to the Q&A. And before I get started, I want to thank Michelle ahead of time for helping me with the slides. I had some technical difficulties this morning. So as the slide says, I'm going to talk about operationalizing health equity during a crisis. The short version of this talk is that you can't expect to deliver a health equity response during a crisis if you haven't laid the foundation beforehand. Without a foundation grounded in equity, what we tend to do is work reactively. And usually what that means is throwing money at the problem, usually to the wrong people. And after the crisis, you're back to where you were before, if you're lucky, and somewhat worse off if events, continue. And so if we go to the next slide, as an overview, I'm going to talk about what it takes to bake equity into crisis response. And I'm going to cover it from the preparedness aspect as well as the response aspect. And specifically, when I talk about the Race to Justice initiative, it's an initiative that began in 2015 when Dr. Mary Bassett was commissioner, and she'll soon to be New York State Health Commissioner, and I was first deputy commissioner. And then the rest of the things on the slide will be initiatives that were birthed under my leadership, either as first deputy or as commissioner. But the important thing here to note is that what I'm going to be talking about is independent of one individual or two individuals. This work is really dependent on having a deep bench of public health practitioners. So along the way, I'm going to talk about ways in which what I'm talking about can be applied to systems, situations more broadly. Next slide, please. So before I get into the actual talk, I think it's important to have some level setting on concepts. And this is a very familiar slide. You've all seen it before. And the way that I look at this slide is it's a cross-sectional depiction of equity. It illustrates that in this moment, there are three people who have differing needs to get to the same outcome, in this situation, enjoying a baseball game. And the three people are supposed to represent three different communities, and the boxes represent resources. But this only covers part of the equity story, because what it doesn't give you a clue about is what's going to happen when the park gets a new grounds crew chief before the next game. And so that's why I like the next slide, because it's a graphic that I think gives a much fuller representation of the equity continuum. It's one that looks at it from a longitudinal perspective. And I love it because it uses the giving tree to illustrate the point about resource allocation. Because first and foremost, it's about something fundamental, right? It's about food. It's not about entertainment. It tackles the issue of structural components that contribute to generations of inequity, which at its root is about power imbalances in resource allocation. And it acknowledges that the imbalance isn't just about these two characters, and that the solutions need to address the underlying drivers of inequity so that the next set of people who need these resources can access them in a way that maximizes the likelihood of them getting what they need for their health and their prosperity. And so what's implicit in this graphic is that the caretakers of this tree saw the imbalance and did something about it. They addressed the short-term needs by placing different sized ladders for the people who needed to access the apples. But they also understood the system they were responsible for and took accountability by putting an infrastructure in place so that future apple pickers wouldn't have to struggle for no other reason than that's the way it's always been done kind of mentality. And if I take the metaphor just a little bit further, I imagine these caretakers are sharing their success with peers around the country so that future orchard growers won't think that these trees are supposed to grow that way and that there's nothing to be done. And lastly, my hope is that these same equity and justice-minded orchard growers are planning with agricultural scientists and others to hardwire equity into new growing systems so that future trees will grow straight without the need for infrastructure support. So that, in a nutshell, is what I hope to illustrate today with what we did in New York City during COVID, and that I think can be applied to any system under any circumstances. So a little bit more on level setting with the next slide. When we talk about structural inequities, and this is a definition that I'm borrowing from the United Nations, it refers specifically to the inequalities that are systematically rooted in the normal operations of dominant social institutions and can be divided into categories like residential segregation or healthcare, employment, and educational discrimination. So let's go to the next slide and let me share a little bit more about the Race to Justice initiative. And so as I mentioned earlier, it's something that we began in 2015, and it's an initiative that acknowledges that operationalizing health equity doesn't just happen. It requires internal transformation for sustainability. And that sustainable change requires more than just leaders or ground troops, as I mentioned before. We need both from the top, from the middle, and from the ground effort. And so Race to Justice is an initiative where we began a commitment to change institutional practices to better position the department to do more transformational equity work. And to say that a little bit differently, it's doing the internal work so that we could show up differently and more authentically in communities and have communities see the degree to which we were committed to having collaborations and not just be extractive in our partnerships. And also in this process to foster an organizational culture that normalizes talking about race, racism, and other systems of oppression and how they relate to health outcomes. Because oftentimes there's the fear of saying something wrong, of alienating people. And from the very beginning, we were clear to say, we're not going to get this right, but we're committed to this process. We're committed to being in it together, and we're going to move forward together. And in that, recognizing that it is really a heavy lift, and we couldn't rely on staff volunteers or for people to incorporate it into their everyday work from the beginning. And so we allocated resources to support the infrastructure change. And the expectation was that the work was going to go beyond trainings. It wasn't, let's check off the box that we've been to this training. It was, how do we apply what we're learning in real time? And let me also say that the New York City Health Department was late getting into this equity game, I will say. There were many other health departments across the country that we took leadership from. But what I will say is that we were the first ones called upon to operationalize equity under the most challenging, the most extreme of circumstances you can imagine. And so the next slide, I'll talk about the three main components that we took upon ourselves to change within this initiative. And let me also just say that I'm going to talk about these, but I'm not going to do a deep dive. You can search DOHMH Race to Justice, and you'll see all of the resources that we put up on the web that were developed as a result of this initiative. But let me just say that the three main areas that we focused on were communications, personnel, and finance, because those are really the guts of an institutional organization. It's what makes it work. So from a communications perspective, we focused on level setting on terminology and creating alignments on community engagement. And the importance of level setting on terminology wasn't to create the PC police about you're using the wrong terminology. It was to create a guide that staff could have to refer to if they had questions about not only the terminology, but how the concepts have evolved over time. And it was a tool that we wanted them to use, not only in talking about race and racism within the health department, but as they encountered folks outside of the health department, and more importantly, to incorporate that terminology in the reports that we put together, in the way that we visualized our data, because the bottom line was that we didn't want to keep using language that perpetuated stigmatizing narratives. The other thing that I will say in creating alignment on community engagement, as I mentioned before, one of the goals of doing Race to Justice was to show up differently and more authentically in community. And if we didn't have a common understanding of what we meant by community engagement, that then could be a source of lack of alignment and frustration amongst staff. So we undertook a fairly comprehensive process where staff in and of themselves created this framework and had ownership of it. And what it did for us was it clarified for folks within the agency who thought, well, we're doing a community engagement because we're handing out information in communities, as well as try to reduce some of the frustration of staff who felt we're not doing community engagement unless we have models that are shared leadership, right? It's not a one or the other, it's a continuum. And I think that really did a lot for us. And it set a very important foundation for the work that we did under COVID, which I'll get to in a few slides. So the next slide talks about personnel. And so personnel, as many of you know, personnel decisions are policy decisions. And under personnel, we focused on recruitment, retention, and promotion. Specifically, we wanted to have a staff that was reflective of the race and ethnicity of the city. And specifically, we wanted to have the leadership, both middle management and executive leadership, be more representative of the city that we served. For a number of different reasons, the unionized workforce was more reflective of the city we served, whereas the non-unionized or executive staff were less reflective of the city we served. So the things that we undertook to address the recruitment aspect specifically is we diversified where we recruited, and we also tapped into networks of staff to work with organizations, for example, like the National Medical Association, National Hispanic Medical Association, and other associations of minority organizations. We also then required that to have racially diverse hiring panels, right, for every executive position that we were hiring for. And we piloted things like a blind resume hiring pool, meaning that we redacted names, we redacted where people went to school, and we redacted any potential racial and ethnic identifiers to give our staff the opportunity to focus on qualifications and experience and not fall prey to the internal bias that all of us have. And so that is still an iterating process, but it gives you a sense of the commitment that we had to revamping everything and anything that could possibly create an additional barrier to having a staff that was more reflective of our city. The other thing that we focused on was promotion. So it's not just enough to hire diverse people. We need to have systems in place to retain them and to promote them. So incorporating things like more formal mentoring processes that are not dependent on where people went to school, and knowing, that pipeline of folks, and really creating an expectation that we would be mentors to one another. And then from the promotion aspect, really teasing out what are the factors that contribute to more promotion, and how do we get hiring managers to be more adept at essentially finding titles that were most appropriate for people to fall into. And then the last thing about finance I will say is that one of the specific areas that we looked at was how we could direct more of the the health department's dollars to MWBE, so minority and women business-owned entities in the products that we procured, and put in place systems so that if there wasn't an MWBE that was available, people had to justify why it was that they were going to a non-MWBE. And as a result, we increased the spending in that category somewhere around 30%, which was significant when you're talking about a human services budget of over $800 million. So let me then go to the next slide, because it's not just about, it's funny, as I was putting these slides together, I was thinking about the national debate we're having on infrastructure, right? And the point is that you can have sort of inner infrastructure, but if you don't have the people infrastructure, then you're never going to make any changes. So I first talked about the people infrastructure and what we did. Now I'm going to talk about, quote unquote, the more inner infrastructure that we leveraged. And we created an online web-based tool that essentially helped us hardwire new workflows into the everyday work of the institution, because human nature is to give into the entropy of the system and go back to what feels safe and established. And we were committed to building an infrastructure that, again, wasn't dependent on just a handful of people, but that really transformed the organizational culture. And so in 2015, my team and I started development of this online tool so that we could have a data-driven decision-making support for more efficient partner engagement, more effective community engagement, and greater accountability in ensuring that the resources that were allocated were best aligned with what the EPI was telling us were the things that were the main issues and the communities that were most affected. And so in short, it's a tool that helped us assess how well we were walking the walk, or were we just talking the talk about operationalizing a health equity agenda. So if we go to the next slide, the three sort of core things that it allowed us to do was to create an inventory of existing partners, a taxonomy for the human services contracts, as well as incorporating the community engagement framework that was built under the Race to Justice initiative. And so the taxonomy of partners helped us better understand if we were equitable in our approach to partners, or were we extracting resources from community without acknowledging their value and appropriately compensating them. And the taxonomy for the human services contract helped us organize accountability by quickly allowing us to determine what we were buying and if that buy aligned with the needs. And so the bottom line is that the key to replacing old workflows was ensuring that staff needs were being met with this new online tool, and that they had all of the supports to meet the most pressing public health issues, or things they were working on that were complicated and messy and needed some order. And so at the end of about 3 to 4 years, we had about 10,000 to 14,000 partners in this application. And as I mentioned earlier, over $800 million worth of human services contracts. Next slide, please. And then COVID hits New York City. And as you all know, we were the epicenter of the first wave of the transmission. And we knew from the very beginning that Black and Brown New Yorkers were being disproportionately affected. And so let me here say that we knew this because the health department has an incredibly sophisticated data system that draws data in from a whole host of resources and sources around the city. But even with that robust infrastructure, more than 60% of the data that we were receiving in the very beginning, primarily from labs, was missing data on race and ethnicity. But we knew that the data that we were seeing was clear about the inequities that were playing out. And so part of operationalizing an equity response often requires making decisions with incomplete data, because waiting for perfect data can come at a very high cost to human health and safety. And so we made the decision early on, even with incomplete data, and almost felt like, breaking one of the cardinal rules of public health, that we were going to act on that data. And so it wasn't just about acting on that data. It was incumbent on us to incorporate the historical factors that predispose these communities to higher risk factors for exposure hospitalizations, and death. So when we talked about Black and Brown New Yorkers being disproportionately affected, we also talked about the fact that they were living in multi-generational households, often mixed status households, because of the fact that housing is so incredibly and unnecessarily expensive in our area, that many of these families were living in overcrowded and unstable housing, making it incredibly difficult to isolate and quarantine safely for the amount of time that we needed them to do so. And that they were more likely to be frontline workers with no health insurance, no significant sick leave, and were unable to work from home. So this wasn't a situation where we were going to even entertain, quote unquote, blaming the victim, but that we were going to shed light on the structural components that contributed to an ongoing transmission picture that we were seeing. And it's in that, I think, part was incredibly important because operationalizing an equity response requires going beyond promoting the clinical solutions. It has to identify what are those solutions within the social determinants of health that need to be addressed as quickly and as importantly as the clinical interventions. So as a result, and the next slide, please, we launched the COVID Equity Action Plan. And so before I get to that, if we can go back, well, actually, you can leave it now. Before I get to that, I want to just go a little bit deeper on the point about Black and Brown New Yorkers being disproportionately affected, because that gets talked about a lot, both in New York City and across the country. But what we didn't talk a lot about in retrospect, and what we should have talked more about, is the fact that in the first 3 months of COVID, there were 29 zip codes that accounted for more than half the deaths related to COVID. And so said differently, 1.6% of New York City zip codes accounted for just over 50% of the deaths. And if that's not the ultimate expression of how your zip code determines your life expectancy, then I don't know what is. And building a response that's grounded in equity, we needed to incorporate short and long-term solutions that addressed more than just the clinical issues. So this slide gives you a sense of the 3 main areas that we focused on with this COVID Equity Action Plan. One was enhancing our community engagement and information dissemination. It wasn't enough that we were all over media. It wasn't enough that we were all over the radio, TV. My face was even on Hulu. I apologize to all of those who kept seeing me. Like, that wasn't enough, right? Because there were so many communities that are linguistically and culturally isolated in the city that we needed to draw on trusted messengers to carry that message for us, not just about what was happening, but about how communities could protect themselves, and in response, feed back to us what were the additional measures we needed to put in place. And so we were able to leverage those partners that we had already put into PHPC, increase them. So we had about over 25,000 partners, and be able to create those direct linkages between those CBOs, communities that were most affected, redirect resources so that those CBOs could support communities in safe isolation and quarantine. Everything from food delivery to, free hotel rooms, to walking your dog and taking your garbage out if that's what needed to happen. And then the other thing that we incorporated was, the fact that, and even to this day, all of the attention is on hospital systems, and rightly so, because people who are extremely sick, that's where they end up. But what we didn't focus on is the everyday importance of primary care practices, right? Because we needed to find ways to offload the demands on EDs. And we needed to have these primary care practices that serve these communities up and running. Because if you think about it, these were small practices and they didn't have the capital in many circumstances to purchase the PPE that they needed. They didn't have the resources to weather, the shutdown that we had to undergo. And so we worked with many public primary care practices in those communities. We facilitated their PPE access, and including working with them with their EHRs, setting up staff to call their patients who were at risk for the worst health outcomes from COVID exposure. So those are the people, for example, with diabetes who were running low on their medications and needed refills, et cetera. So the work of the health department, I think, in this equity response, included everything from ground level calling individual people all the way through to dealing with systems issues. Next slide, please. And actually, before you do that, and this all happened between March, April, and May. And then at the end of May, next slide, George Floyd gets murdered. And one of, I think, the most important things that I could have done during this emergency response, in addition to everything else we were doing, was issue a statement from the health department being clear about racism as a public health crisis. And the fact that even though we were undergoing the most challenging and dramatic communicable disease issue in our lifetime, a pandemic of the century, it was just as important as us dealing with racism as a public health issue. And we couldn't put one aside to deal with the other. And we had to deal with each as they came. Because again, part of mobilizing an equity response is calling out the major threats during an incident. So next slide, please. So what I'm going to do next is give some examples of how we then were able to mobilize specific aspects of the response. But I wanted to say, first and foremost, that even though clearly Mr. Floyd's murder sent us reeling, it didn't derail our response because we had done the work up front through Race to Justice and through all of the other initiatives we had done in the health department. People had the language to express the rage that they were feeling, and they understood the infrastructure that we had put in place in order to not just, as I said, address the clinical, but address the underlying issues that needed to be addressed and that were contributing to ongoing inequities. And that included, for example, putting out messages about safe protesting, right? So it wasn't one or the other, it had to be both. And the examples the additional examples I'm gonna share were possible because, again, we were drawing on an existing infrastructure of data and management expertise. So next slide, please. One of the things that we did early on was we convened a community advisory board from a number of different CBOs that were key partners for us. And this was a learning that we had done during Ebola, where we convened a community advisory board because of the fact that New Yorkers from various parts of Africa were being stigmatized because of the ignorance of a certain number of people within our community about what the real risk factors were in Ebola. And similarly, those prejudiced approaches and bigoted approaches were playing out here in New York City. And in addition to that, needing to mobilize resources quickly. So they were an invaluable component of the equity response. But beyond that, they kept us real. They told us when our efforts were going above and beyond and were seen as punitive. And they, opened our eyes to things that we were not taking into consideration. And so this board was critical because there were lots of layers to what needed to be addressed in the immediate period, but also because it was becoming a more and more complex response that wasn't just about an infectious disease. It was about another communicable disease, racism, that was a significant comorbidity in all of this, not just here in New York City, but certainly at the state and national level. So next slide, please. So this is an example of the kind of reports we were able to generate from PHPC. And I'm not going to get into the slide at all, but what I will say is that part of the equity response is sharing information back with partners and creating enhancements that meet partner needs, which allows partners to see themselves in the response. So it's not just about them helping us, it's about them and us helping the city. And so I love the quote in this slide, which is, seeing the full dashboard has been so helpful in helping me celebrate my team and the work we're doing to help stop the spread. Next slide, please. This slide is also a reminder that, again, it wasn't just about COVID. It wasn't just about COVID and racism. It was about COVID, racism, and, heat waves. And so another way in which we operationalized an equity response is in the middle of all of this, leveraging those partners to ensure that seniors who lived in those 29 zip codes got first priority to free air conditioners that we were giving out because, of course, cooling centers were closed. And so, looking at this from an equity perspective, again, was about not relying on first come, first serve, but really making those equity adjustments. And next slide. The other area that I think is important for us to note is it's not just about the data that you have, but it's also about the data that you don't have. And looking at the early childhood centers was one of those critical areas that opened my eyes to data voids. And so early childhood centers, like everybody else, had to close, when we went into New York State pause. But in phase one, when we were starting to open society again, if you will, what we found was that in surveying the different sectors that we needed to reopening to see what their needs were from the health department, we got a good response from early childhood centers, but something in my gut said, let's see how representative this is of the city as a whole. And sure enough, what we found was that early childhood centers in the South Bronx and Central Brooklyn weren't responding because they had shut down. They, again, small businesses typically run by women of color, didn't have the capital to weather the storm. And so this really helped to shine a light on how the social determinants of health were so critical and still are so critical in mobilizing this response, that if we thought about the ripple effect of these centers, it was small businesses run by women of color that were closing, small businesses that were providing a service so that other women of color could stay in the workforce that weren't able to do so. And they were oftentimes, the vast majority, centers where children of color could access high quality early childhood education, which is one of the most important factors for setting kids up for success, for education and health outcomes. And so early on, we were only able to provide a limited amount of resources, but in the long term, this is a sector of our society that needs much more support. And it played out here in the city, and it's playing out nationally in terms of providing that kind of infrastructure support so that women can get back into the workforce. Next slide, please. And so as we look for opportunities to further operationalize a health equity agenda, let me just start by saying that the work of undoing the legacy of structural racism is a marathon that goes beyond one individual or two individuals. It requires a deep bench of people equally committed to sustainable actions that counter the institutional inertia of racism. Next slide, please. And so recently, October of this, I would say 2 weeks ago, the Board of Health for New York City passed a resolution declaring racism a public health crisis. And within that, set out requirements for the health department that requests of them to review the New York City charter revisions and make recommendations on anti-racism and health-related revisions within that, to look at the New York City Health Code and do an anti-racism review, and to work with sister agencies that are responsible for the social determinants of health, transportation, education, housing, land use, and work with them to make recommendations to undo racism within policies, plans, and budgets related to the social determinants. So this is really a dramatic statement on the part of the Board of Health. And I think it will help to chart a course moving forward that, again, will endure beyond the individuals that are currently at the health department. And as I finish up with my slides, big picture moving forward, I think for the health department in the New York City, the challenge is to evaluate changes over time resulting from an anti-racist and equity trainings that have been done, the policy changes and the practice enhancements that have been put in place, and to increase transparency and accountability with the public about where and to whom dollars are going for human services, and for our country to support public health departments across the country to do similar work, and for there to be incorporation of operationalizing health equity in public health curricula. Next slide, please. And clearly there are challenges and opportunities. You know, some people may see this as challenges and see the same thing as opportunities. But, you know, what I see is first and foremost that results take time. And so it's important to talk about that up front to help and reduce the ongoing frustration that many people will have with the speed in which changes happen or don't happen. And it's, you know, these things took generations to put in place, and it will take significant amount of time to undo, hopefully not more generations, but a significant time nonetheless. The other thing is that there's been a mass exodus of public health workforce, and that potentially threatens the ability to institutionalize an equity approach. And so that's a big threat. But on the other hand, there's lots of people that want to go into public health, and maybe they will be more prepared to leverage the equity promoting structural tools that they're learning in school and that they've seen in other parts of their lives. But most important to all of this is ensuring that public health funding not only needs the basic needs of what public health needs to do, but also acknowledges that sustaining an equity infrastructure is part of the core work of public health, governmental public health across the country. So next slide. I want to thank you all, and I want to turn it back over to Perry for questions.
Thank you, Oxiris, for that amazing talk. I really appreciate your thoughts, your ideas, your slides. And I want to say, I think it's like music to my ears and the music to many of our ears for a school that's really rooted in the tenets of social justice and health equity. And it's really trying to advance this notion that health conditions cannot be thought of separate from education, separate from climate, separate from racism, that all of these things collectively influence the health of people and population. So it was amazing to hear you articulate that in this such an incredible way. So thank you. I'm going to ask you the first question, and then folks who are on the camera and stuff, I see questions inside. I will call you so that you can ask your question, because that'll just make it a little more entertaining for Dr. Barbeau and all of us, rather than hearing just me. But I want Dr. Barbeau to talk about the issue of, you've talked a lot about engaging with, working with, speaking to, understanding, giving voice, de-silencing populations, right? And how important that is as we fight COVID or any other health condition, whether it be obesity or cigarette smoking. I mean, folks know, I think my colleagues and I would be the first to say, people know what they need. People know what their challenges are. Speak to people, right? Mandates. The federal government has, and other entities, private entities have decided that mandates is the way to go forward with COVID-19. Clearly, there's a lot of resistance to that. What are the lessons? I'm not asking you to take a stand. I'm going to ask you, what are the lessons learned from the work you've done in New York City and in Baltimore and in the Department of Education that should have informed or could have informed or did inform the decision-making process around mandates that Uncle Joe and others have adopted over the course of the last month?
So that's a really great question. I think, first and foremost is the importance, and I speak about this not only as, someone who had to go through this in New York and in Baltimore, but as a pediatrician who had to do this day in and day out with families, right? It's about, as you say, giving people the information that they need in order to feel good about the decisions that they're making to protect their health, the health of their family, and the health of their communities. I was in practice for 10 years in the 90s. Our reality is much different now than it was then in terms of how that information is digested, because we in public health have to fight against misinformation and disinformation in social media. Doesn't take away from the fact that we have to lean into that information sharing even more. It then reminds us that it can't just be about government delivering those messages. It has to be about enlisting trusted messengers in communities. It has to be about calling out that misinformation. That being said, we also need to take note of where transmission is going or not, so that if after a while of putting carrots and sticks in place and you're still seeing widespread transmission, then I think it's incumbent on all of us to really look long and hard at the spheres of influence that we have to make the determination about whether or not mandates are the way to go. I will say, in looking at what's happened, I've been really surprised that it's been big business that has led the way in terms of mandates, right? I feel like I'm living in a different universe, because when you have United Airlines, when you have, other big businesses saying we are going to mandate immunizations, and you have government shying away from that, it kind of makes you wonder, what are we missing? What have we ceded? What have we in public health and government ceded to social media and to big business? So I applaud people or people. Supreme Court determined that they were people, but that's a whole different talk. I applaud institutions who take it upon themselves to pass mandates. And what they found was, people will kick and scream and say, I'm going to quit. But at the end of the day, very few people resigned from United Airlines, other airlines that put in those mandates. Very few people across the country have resigned. There have been a significant number of people in hospitals that have resigned, So I think that, where this is going to fall out is to be determined. But Dean, to answer your question more directly, I think that there's a time and a place for mandates and that we can't shy away from them to protect the health and welfare of not only individuals, but our society.
Thank you, Dr. Barbeau. It's so the first part of your comments, which dealt with misinformation, and your comment back to the early '90s, it's almost like, for those of us who are old enough to remember, many of you are not, this idea of urban legends, right? And there was just like these myths that existed, that actually are depicted very beautifully in a movie called Urbania, but that sort of like took hold and people spread off as wildfire. And now this is like, a million times more powerful with social media, that these myths just perpetuate. So I appreciate your call out to that, and, the role and the struggle we have and the challenges we have in dealing with all of that misinformation out there. I think it's really, really key. I'm going to now turn it over for the next question to somebody you know very well, who is your colleague and now is thankfully our colleague, Kevin Scroth. Kevin, all yours.
Dr. Barbeau, it's good to see you. I was in the tobacco control group, as you may recall, up until 2018.
Yes.
I have two questions. I wrote a question down, and it was, to what extent did the challenges of having people working from home in large numbers affect the response, and did community health centers help provide a foothold to help reach some of the communities in the greatest need? So that was my first question. My second question is more of a big picture, fundamentally crucial question. And I know that there was some tension during your last days at the commissioner, and I'm wondering if you have any thoughts about leadership and courage, because I thought I was really inspired by the way that you handled the last few weeks of your tenure, where there was some conflict. So I'll just leave it at that and see how far you want to get into that.
Thank you, Kevin. I appreciate the questions, and I appreciate your sentiment in terms of what happened in the last couple of weeks. I think that, and I'll take the second question first, because these are times that have tried all of us and that have tested our resolve in terms of institutions and in terms of individuals. And, one of the things that I go back to is that this response in many ways went beyond individuals who were, quote unquote, leading the response, right? That certainly leaders influenced how the response was going, but in the end, it was about kind of bigger things than that. And so I felt like me sort of being in the crucible of the stuff, for lack of a better term, was just, the universe puts you where you need to be, when you need to be there, with the people that you need to be with, in order to make sure that you do the most that you can to protect the most people. And so it was a response that was about the value and the importance of public health for the health and safety of not only our city, but our country and our world. And, it was a dynamic that unfortunately was a dynamic that played out in other parts of the country, but it is one that I think we will need to grapple with more within public health and within government to determine how do we protect, quote unquote, public health from influences that are more driven by economic or special interests, where they should be driven more by the health and safety of a population. How do we protect the institution of public health when you have, the different blowing winds of political capriciousness. And so it was not an easy period, but in the end, I couldn't have thought of a better place for me to be, because I have had an amazing team, and I had a trajectory, I think, that provided me a very clear equity lens that I think ultimately made a huge difference in how COVID played out in this city, which is very different than it played out in other parts of the country. And so I feel proud of the way that in which the health department worked collaboratively with our sister agencies, and more importantly, with New Yorkers, which takes me to your second question about working from home. It's a hard question, because some people didn't have the luxury of working from home, and those that worked from home were able to demonstrate oftentimes that they were just as productive in the heat of an emergency response. And so I think, again, it will be a fantastic case study to determine not only what work we do, but how we do it, and how we define productivity, and how we continue to engage communities. That was a great set of questions, Kevin. Thank you.
Great answers, too.
Thank you, Kevin. Yeah, and Dr. Barbeau, I want to just echo something, sort of at the sentiment I think that Kevin was expressing. I mean, I'm asked on many occasions, what are the characteristics of a leader what is the most important characteristic of a leader who seeks to implement diversity, equity, inclusion initiatives, and to implement anti-racism and to fight racism and structural racism? And my answer is always this: bravery. Right. And I think that you and your team were incredibly brave throughout this crisis, dealing with the epidemic, but also dealing with the political realities that you were facing at the time. And I watched you and I was like, okay, I can fight on. If Oxiris can fight on, I can fight on too. So thank you for that. The next question is going to come to you. Oh, go ahead, Oxiris. Go ahead.
I'm going to add one thing to that, because in my career, I often give, young public health leaders advice, having been in the public spotlight for a while in different cities. And I always tell them, you need to know up front what you're willing to fall on your sword for, and understand that sometimes what you think you're going to fall on your sword for actually ends up being resolved, and you create a little bit more capacity to hold things that are untenable. But when that moment comes, when you know that this is it, then there's a lot of clarity, and there's a lot of groundedness in that. So I think it's important for people to know that up front.
For that. The next question comes from our chair of our Urban Global Public Health Department, Dr. Leslie Cantor.
Dr. Barbeau, thank you so much for joining us today. It's great to see you. So what should we be doing in the field of public health so that we're more ready for the next crisis?
Oh my gosh, in 2 minutes or less, right? I think first and foremost, it's recognizing that this period in time is is analogous to 9/11, right? Where after 9/11, lots of people wanted to go into public service, wanted to go into the military, wanted to go in different areas to protect our country, right? And the motivation behind that was pure, and it was heartfelt. I see that same thing happening now, where a lot of people want to go into public health. A lot of young people want to go into public health. And I think building systems that have the capacity to nurture them through that, and to harness their idealism. And I don't say that in a condescending way. I say that in a truly loving way, because I think that's what's going to help public health transform itself into its next iteration, and leveraging the passion of these young students who have been protesting, different issues that have come up in their lifetime, be it climate change, be it racism, be it economic injustice. I think thinking more broadly about what constitutes the core skill set for a public health practitioner and incorporating that into the curriculum and leveraging that passion to change how we do what we do is really exciting. I think you all are in a really exciting place to do that for the field.
Thank you. I have a question from one of our colleagues who is apologizing because they're in a loud location preparing to vote. So yay, Darren, for preparing to vote. Otherwise, they would ask the question themselves. But this is what Darren asks. It appears that your approach to addressing COVID was equity-centered, or an equity-centered practice, which is different, in my opinion, than having an equitable infrastructure. Am I off base with my assumption, or do you feel that you have established such an infrastructure and the needed components to be successful?
So it's both. I'm going to read into that question because, you're in a loud place. But I would say, if you think about infrastructure from the perspective of public health having all the resources that it needs, then no, it's not equitable. But if you think about the infrastructure that we built with the resources that we had to facilitate an equitable response, then yes, we did, because the infrastructure we built, and I'm talking about the health department, I'm not talking as much about sort of the broader infrastructure the city had, although we were able to significantly influence that as well. Our incident command structure incorporated an equity unit, same as it incorporated, a provider education unit or a data and analytics unit, which is very different than the ICS structure that we had when Kevin was a part of the health department. And so, it's a combination of making equity a part of everybody's work, but also recognizing that in crisis situations, there is a necessity for people to sort of splinter off and focus intensively on components of the response to then be able to come back together to make that response that much stronger.
Thank you, Dr. Barbeau, for that. And I hope you heard that, Darren, and thank you again for voting. Because voting is related to public health. I'm now going to ask our former student and now Assistant Director for Student Support Services, Claire Brown, to ask you a question about, which I think has to do with students and careers. Claire?
Yeah, sure. Thank you. Thank you, Dr. Barbeau, for your talk. And I know we do have some students on the call who are really excited to be here as well. I was just wondering, as someone who meets with students frequently for career advising and helps them think about the different pathways they might pursue, what advice you would have for current students or some of our soon-to-be graduates who might be hesitant now about pursuing careers in state and local governmental public health, either due to lower funding compared to some private sector jobs or seeing other people leave the workforce during the pandemic. Just wondering any encouragement you might have for these students about, hope for the future, the importance of these career pathways.
Yeah, absolutely. My first response to students interested in going into governmental public health is first and foremost to have eyes open about what they're getting into. Staff that we hired at the health department, I would say 99% of the people that we hired because of their commitment to mission, not because of their commitment to dollars, right? You're not going to make $1 million when you go into public health, but at the end of the day, you're going to be able to look at yourself in the mirror and feel proud of the work that you're doing to serve your communities. And so that's really important. The second thing I will say is that it's as important to have public health trained people in other sectors as it is in having them in governmental public health. So if you want to go into governmental transportation, housing, God bless, we need you there as well. So it's not an issue of, if I don't go into governmental health, or if I don't go into an NGO that does, public health, then I'm putting my MPH to waste. No, on the contrary, you are going to be then one of the leaders within that sector to carry the torch of public health. And we need more people like that. So again, we know when I say it's an exciting time to be in public health, I mean that sort of more expansively to incorporate not just governmental public health or academic public health, but public health writ large. Because if anything, COVID has taught us with great acuity how important public health and a public health approach is to every aspect of our civil society.
Thank you, Claire, and thank you, Dr. Barbeau, for that response. I think that we are seeing, all of us in schools of public health, increasing number of students who are committed to the area. What we need to do, and I think we're all committed to, is making sure that those students continue to stay in this space, are not frightened off by what they're seeing on, I don't know, Fox News, and continue to do the good work. The next question comes, I'm sorry for all the dinging. The next question comes from our Director for Center for Public Health Workforce Development, Mitch Rosen. Mitch, all yours.
Thank you. So people don't live single issue lives. We all have many factors that influence our behavior and impact our health. And public health departments are responsible for so many things, a broad spectrum of health issues and dealing with those things. So with so many important issues facing society, including racism, inequity, climate change, and environmental health issues, the pandemic, worker safety, and all of our quote unquote regular public health challenges, how do public health agencies prioritize their resources? And how do leaders decide on what issues they should prioritize within the department?
Great question. I think first and foremost, I need to be realistic to say that oftentimes we are forced to prioritize what we get money for, right? Like that's just the reality. However, and this is actually something that I started to do when I first became commissioner, but that truthfully got derailed because first I had measles, the biggest measles outbreak in New York City in 30 years to deal with. And then shortly thereafter, all hell broke loose with COVID. But to your point, from my perspective, looking at it from an equity lens, I look at the data first, right? And so when I looked at the data that New York City had, it was clear that we needed to focus on reducing racial inequities in premature mortality. That to me was like the end game, right? And then break down what's contributing the most to premature mortality. And what we found was, and I think this got buried somewhere because again, all hell broke loose, but in the past 10 years, diabetes went from being maybe like the 12th leading cause of death to before COVID hitting up to like the 4th leading cause of death. And nobody's talking from premature mortality, and nobody's really talking about that. The other thing that focusing on premature mortality does for us is that it creates this space to talk about the social determinants of health from a very real perspective, right? And we were able to then incorporate, for example, what difference a living wage or a minimum wage in New York City, $15 an hour, would have on premature mortality outcomes. And so by having that as your organizing principle, you then create a research agenda that supports the contribution of social determinants, not just in terms of, like, for example, a living wage, but how does housing then contribute to premature mortality? And all of a sudden you're creating, a huge agenda to prioritize the work within what you're already being funded for, but from an equity perspective. So hopefully someone else will take up that sort of framework, because I think it's one that helps to resonate the fact that the ultimate job of public health, I think, is to help people, keep people from dying before their time in a way that supports quality of life. I mean, that's just the basic thing for me.
Excellent. Excellent. I take this I'm going to do this last question. I take in for inspiration for asking this question from inside the actor's studio, where James Lipton would ask the actors and the directors, like, a word you hate and a sound, all of this like cool stuff. So this is the Perry Halkitis version of that. And I ask it to most people, and I'm going to ask it to you, Dr. Barbeau. Population health, public health. How do you understand those two concepts, those two areas, and differentiate them, if you do differentiate them at all?
I definitely differentiate them, and I have somewhat of an allergy to population health because, in my mind, it's a term that's been co-opted by the healthcare delivery system to talk about providing care, but really they're talking about providing care to people that are in their panel, and they're not talking about communities.
I love your answer. Thank you for that. And thank you for, validating what I wrote in an article last year. I now know it's correct because you said it also. So good. Yay, check. Thank you for that. And thank you for being here with us today and for this remarkable presentation you've given and for your generosity of spirit and the great work you've done and will continue to do. You are a dear friend of our school, and we will see you again. Everyone, a round of applause for Dr. Barbeau.
Thank you. Thank you all.